Welcome to Part 3 of the Delirium Diagnosis and Management Workshop by the Cognitive Impairment Research Group at the University of Limerick. In this section, we will cover the clinical subtypes of delirium, as well as how to differentiate delirium from other diagnoses, such as dementia and depression. We learned in Part 2 that delirium is diagnosed using clinical criteria such as the DSM criteria, now in its 5th edition. However, not all delirium is the same. It presents with highly variable symptomatology from patient to patient, and hence lends itself to subclassification. Over the years, there have been multiple suggestions as to how to subcategorize delirium. However, the most intuitive, most widely accepted, and most validated method is based on motor presentation. The two major categories are hyperactivity, where a patient is restless, agitated, and passively hyperalert, and hypoactivity, where a patient has slowed down and is lacking in spontaneous movement, each of which were recognized by the ancient Greeks, who used the terms lethargicus and phrenetus to describe these subtypes. Now we recognize that patients can also present with a mixed subtype, in which they demonstrate features of both or fluctuate between the two. Please check out the following link to see how a patient with delirium may present. Note that the patient fluctuates between hypoactive and hyperactive motor behaviour. As you watch the video, I want you to consider which of these motor presentations is the most common in clinical practice, and which is the most serious in terms of prognosis. Welcome back. So firstly, which of the subtypes is most common? Studies show that the frequency of the different subtypes does vary across populations, but overall, hypoactive subtype is considered the most prevalent, particularly in older patients who are especially vulnerable to delirium. This seems counterintuitive to many, because many believe that delirium is synonymous with agitation, but this belief is incorrect, and one of the major reasons why delirium is vastly underrecognized. The second question speaks to the relevance of subcategorizing delirium into motor subtypes. There are important differences between the motor subtypes, not only with respect to prevalence, but also in terms of detection rates, prognosis, and non-motor clinical features. Unfortunately, despite being the most prevalent presentation, hypoactive subtype is the least recognized and associated with the worst outcomes. Hypoactivity can be difficult to detect because it is more subtle in presentation and isn't perceived to cause the same level of management problems than hyperactivity. Recent studies have shown that 70 to 80% of hypoactive cases are missed by clinical staff. In Part 1, we discussed how delirium is associated with serious adverse outcomes independent of other confounders. When we look at the individual motor subtypes, in general, hypoactive delirium has been shown to be associated with worse outcomes, such as longer length of stay, in-hospital complications, and increased mortality. An important point about delirium motor subtypes is that they are similar in relation to neuropsychological profile, including cognitive profile, but differ only in relation to neuropsychiatric symptoms. Therefore, it is important to remember that delirium is a unitary concept, despite differences in clinical presentation. This is important in relation to how delirium is and should be treated, and will be discussed in greater detail in Part 4. Now we will move on to discuss the challenge of differentiating delirium from other neuropsychiatric giants. Firstly, we will examine the interface between delirium and dementia. So what do we know about the relationship between delirium and dementia? Firstly, delirium and dementia very often coexist. About 50 to 60% of delirium occurs in the context of dementia, and up to 90% of dementia patients admitted to hospital will have delirium at some point during admission. Because of the superficial similarities in presentation, delirium is often misdiagnosed as dementia, again because of a lack of awareness and understanding of delirium presentation. We also know that patients with delirium are more likely to suffer persistent cognitive decline. For example, they have 2 to 3 times the risk of dementia subsequent to a delirium episode. Hence, delirium contributes to dementia, and dementia predisposes to delirium. To illustrate how to differentiate delirium from dementia, I am going to discuss a couple of cases. I want you to pause this presentation for a minute or two, read this case, and consider what information do you now require to help make a diagnosis. Welcome back. So hopefully, you've correctly considered that you need to ascertain the patient's baseline function in the nursing home, as well as the temporal onset of symptoms and a description of the nature of the symptoms the patient has. You need therefore to get detailed collateral history from nursing staff on the ward, and very importantly, the nursing staff in the nursing home. This table outlines the major differences between delirium and dementia. Both these diagnoses can involve generalized or global impairment of brain function, but there are very important differences. Firstly, the temporal onset is different. Delirium is acute or subacute in onset, occurring over hours or days in general, whereas dementia has a more insidious onset, usually over months to years. Secondly, delirium has a fluctuating course and is generally considered to be reversible, whereas dementia is progressive and irreversible. Furthermore, in delirium there is a disproportionate impairment of attention, whereas in dementia other cognitive deficits predominate. For example, the amnestic profile of Alzheimer's disease. Additionally, when it comes to level of consciousness, one of the core features of delirium is that consciousness is clouded or impaired. In dementia, consciousness is preserved until the later stages, unless of course the patient has delirium superimposed on dementia. Now, coming back to Bridget, pause the presentation again and read the following extra information. What do you think is the diagnosis? She fits the DSM-5 criteria for delirium. She has inattention as she cannot do the months backwards and cannot engage for the entire assessment. This change has occurred over the past few days. She is different from her baseline. She is usually orientated, chatty, and able to follow conversations. She now also has cognitive deficits other than inattention, by virtue of her current disorientation and MMSE score. This is not better explained by any other diagnosis. She may have some cognitive impairment or even mild dementia at baseline, but her current presentation is very acute. And given her admission with severe pneumonia, there is definitely an identifiable medical cause. Now, moving on to another case. Again, pause the presentation, read the case, and think about what information you require to make a diagnosis. Welcome back. So essentially, you first need to assess the patient, but also you need a thorough collateral history again. You go to assess her and the following information is available. Pause the video again to read this slide and consider what you might want to ask the patient's daughter. The main information you need to find out is again this patient's baseline. You were unable to get any important or relevant information from the nursing home. Does she have a history of cognitive impairment or dementia? Does she have behavioural features at baseline? How was she the last time her daughter spoke with her? A detailed collateral history is crucial. One method of structuring this part of the assessment is to use a questionnaire such as the IQ Code or Informant Questionnaire for Cognitive Decline in the Elderly. This instrument has been validated as a screening tool for dementia and is particularly useful in the acute setting, when cognitive assessment is often confounded by other factors such as delirium and physical illness. Using this instrument, you ask the relative whether or not there has been a change in each of 16 features over the previous 10 years and score the response. Mean scores of 3.5 and over are generally considered to be associated with premorbid dementia in older inpatient populations. However, no matter what system you use, the most important thing to remember is that detailed collateral history eliciting information about the onset and nature of symptoms is crucial to help come to a diagnosis. Think back to our first case, Bridget. Remember, she did not have any living relatives, So you would be unable to use the IQ code in this setting. Perhaps discussing her case with her GP may help differentiate whether she has cognitive impairment at baseline and whether she has changed much in recent years. Now moving on to the other major differential diagnosis for delirium, depression. Because delirium, dementia and depression are commonly mistaken for each other and also often coexist, they are known as the 3Ds. Hypoactive delirium, particularly, is regularly referred on to psychiatry liaison teams in the General Hospital as depression by other clinicians because many features of the two overlap. This study, conducted by our group here in Limerick, examined the overlap between these two conditions. Importantly, 50% of DSM-4 major depressive disorder met CAM criteria for either full or subsyndromal delirium, and similarly, over half of delirious patients met criteria for major depressive disorder. Now we will consider another case. Again, pause the video and read the case, and consider what information you require. So yes, we need to fully assess the patient and get thorough collateral history as before. But how can we use that information to help differentiate delirium from depression in this patient? In the study I mentioned earlier, we explored the extent to which clinical features distinguish the two conditions. And what we found was that there were many features which occurred with similar consistency in both delirium and depression. For example, the somatic features of depression. Interestingly, core features of depression such as low mood and anhedonia only moderately differentiated between the two, because patients with delirium commonly express these symptoms. The most significant differentiating features were mainly the cognitive distortions of depression and the core features of delirium, as illustrated on this slide. So it is important to outrule delirium before diagnosing depression. Interestingly, we compared performance on the digit span test, a test of attention, between the two groups, and found that although inattention can occur in major depressive disorder, severe inattention was significantly more common in delirium. This again emphasizes the importance of attention testing in delirium assessment. This recently published review article describes some of the important features which distinguish delirium from depression. Again, delirium is acute in onset, whereas low mood and depression usually occurs over a longer period. Additionally, in depression, low mood is sustained, whereas in delirium, patients more commonly demonstrate fluctuations and lability of affect. Furthermore, although impaired consciousness, psychotic symptoms, and sleep disturbances occur in both conditions, there are inherent differences in the nature of these symptoms as they present in delirium versus depression. So in summary, in this section of the workshop, you have learned that delirium can present with different motor subtypes: hypoactive, hyperactive, and mixed. There are important differences between these subtypes in terms of prevalence, detection, and prognosis, hypoactive subtype being the most common, least detected, and associated with the worst outcomes. Nonetheless, delirium remains a unitary syndrome, which is important when it comes to management. Differentiating the 3Ds can be challenging. Collateral history as well as thorough assessment are crucial. And remember that teasing out the details of the context, course, and nature of the symptoms help to guide you in making an accurate diagnosis. I hope you found this section of the workshop helpful. Next, watch part 4 to learn about how to manage delirium.